It's the first GECHO I attend, so I hope you all, wish you all a good 2023. And it's very nice to see some familiar names. We can't really see the faces with us. As you know, the GECHO meetings are hosted by the Gastro Foundation in association with Project ECHO from the University of New Mexico. These sessions are held weekly on a Wednesday. This is a new platform that I think that's just been introduced, a little bit different from the previous one. So we can't tell you exactly how many registrations we've had for this meeting specifically, but there are 291 people that have registered for all over for the Wednesday meetings. And then the chat will be open for any questions. So it's really a pleasure to introduce Professor Mark Benon from the Department of Surgery at the University of Cape Town. He's a hepatopancreatobiliary surgeon, but also an interventional endoscopist in the field of HPB. He's going to talk to us on the use of plastic stents in patients with obstructive jaundice, and also tell you about a stent that we've started some year ago where we randomize patients between 2 plastic stents versus metal stents. As you know, there's a big price difference that is a problem for probably most people, but specifically for us in areas where resources are often a problem. So over to you, Mark. Marcus just lost his internet. He'll be with us just now.
Okay.
We've had a slightly unstable connection here with EduRoam. You'll join just now, Cheryl, so when he joins, just let him in.
Will do.
Hi, everyone. Sorry about that. I hope the internet will be better now. I'm just going to share my screen. Can you see that, Ed?
Yes, Mark, we do.
Okay, thanks. So I missed the introduction, but thanks for the introduction, Ed, and thanks to the Gastro Foundation and Project ECHO for asking me to give this talk. So the title is The ABC of Plastic Stenting for Bile Duct Strictures and the Preliminary Results of Double Plastic Stents versus SEMS trial. So I think to understand where we are with stents and when we should use plastic stents versus metal stents and the best type of stent to use, it's worth just considering where we've come from. So the first endoscopic biliary stent was a plastic stent that was placed in 1979. It was a 7 French plastic pigtail catheter. And at that stage, the initial duodenoscopes had very small instrumentation channels and bigger stents couldn't be placed. The problem with these small stents was that there was a high incidence of cholangitis. Hebrechtster and his colleagues were the first to place larger stents in Amsterdam in 1981 using a forward viewing gastroscope. And they started placing 10 French, straight 10 French polyethylene plastic stents that had a flap at each end. And these are often referred to as cotton Hebrechtster or Amsterdam type stents, and are probably the most commonly used plastic stents. Over the next few years, the duodenoscopes with larger channels were developed, and in 1981, there was a trial done, and it was published, and it started, and it was published in 1982 by the Amsterdam group, where they put 10 French stents into 45 patients, and the results were significantly better with respect to stent dysfunction and cholangitis than with the smaller stents. So this stent sort of became the workhorse stent in the early 80s. Although this talk's supposed to focus on plastic stents, I think you can't talk about biliary stenting without mentioning metal stents, and I think that seeing we are in Southern Africa, I think it's worth pointing out that the prelude to the current metal stent was developed in Zimbabwe, and in a hospital that I see honor size on the meeting, Harare Hospital, which is still a functioning hospital in Harare. And this, Colin Didcott didn't really get the credit for I think basically inventing metal stents. So those stents were used in the esophagus. The initial biliary self-expanding metal stents were first reported in 1989, and the initial ones had a diameter of 8 to 10 millimeters. So if you go back to 1982, when the first 10 French plastic Amsterdam type stent was placed, there were numerous studies comparing different types of plastic, polyethylene, polyurethane, polytetrafluoroethylene, and different types of plastics, and none of them were shown to show any difference. The one thing that did seem to make a bit of a difference was the size of the stent, and as the size goes up to sort of at 10 French, there doesn't seem to be much more of a benefit of going bigger. There does seem to be improved patencies. But one has to balance the ease of stent placement versus patency. And like I said, the 10 French Amsterdam stents became the main stent that was used. Then with the development of those metal stents in the late 80s, there were 8 trials comparing plastic stents to self-expanding metal stents. We did one of them, and basically all of them concurred that when it comes to distal biliary obstructions, metal stents have a lower incidence of stent dysfunction than plastic stents, and certainly for distal biliary strictures, I think metal stents have become favored for that reason. So what are some of the advantages and disadvantages of plastic stents? Well, one of the important things is plastic stents are easily removable, especially if you compare them to uncovered metal stents. They can be safely deployed above the biliary confluence without blocking side ducts, which is obviously a problem with covered metal stents. Multiple stents can be deployed adjacent to each other, and that allows progressive dilatation. You can dilate to more than 10 millimeters if you put in enough stents, which is sort of the limit for metal stents. Drainage can occur in between plastic stents. So if you put multiple plastic stents, you can get drainage in between. And I think especially with stone disease and if there's lots of debris, or if you're worried about tumor ingrowth, that is potentially an advantage. And then they are cheaper than metal stents. Like I said, they have a low patency rate, they have a risk of migration, and often it is more difficult to get a plastic stent across the stricture than it is to do with a self-expanding metal stent. So if you look at the preferred uses for plastic stents, when would you prefer to use a plastic stent rather than a metal stent? I've basically put those instances in bold text. So for stone disease, we generally prefer plastic stents. If you look at distal strictures, so strictures that don't involve the biliary confluence, we would prefer to use plastic stents, certainly for benign, well, you could use them for benign strictures, such as anastomotic strictures after liver transplantation or chronic pancreatitis. And then when we look at hilar strictures, certainly resectable malignant strictures, we prefer to place plastic stents. and they are also frequently used for benign hilar strictures. I'm just going to go into some of these indications in more detail. So if you consider distal benign strictures, the common etiologies are chronic pancreatitis, post-cholecystectomy strictures, anastomotic strictures following liver transplantation, autoimmune and IgG4 related strictures, primary sclerosing cholangitis, and HIV cholangiopathy. And when you manage these patients, the goals of your treatment are to exclude malignancy, relieve the jaundice, and then the long-term goal is continuous radial pressure on the stricture. And it's been shown that prolonged stenting over a 12-month period is associated with a much better outcome than shorter-term stenting. So, you got this choice of plastic and metal stents, and there've been quite a lot of studies comparing the two. Most of them have been in patients with chronic pancreatitis or post-transplant. And what they all seem to show the same sort of thing is that stricture resolution rates are similar. Some of the studies suggested it was slightly better in the metal stent group. There's certainly more procedures in the multiple plastic stent group. Migration is more common in the SEMS group. And although the cost of a self-expanding metal stent is higher, you need to balance that against the fact that the patients who get multiple plastic stents generally have more procedures. And the optimal timing of stent exchange is not sort of been proper. Well, there's some controversy about it, but if you look at most of the studies, the plastic stents are exchanged or additional stents are added every 3 months or so, and generally with the metal stents, they exchange every 6 months. And you can see in this diagram a 10 millimeter diameter metal stent, which has 7 10 French plastic stents inside. So basically, 7 10 French stents is equivalent to a 10 millimeter metal stent. So I'm going to go on to talk about malignant strictures, and you can see that's not in bold because, like I said earlier, there have been all these trials that have shown that metal stents are certainly better than single plastic stents. But considering what I've just said about benign disease, could there be a role for multiple plastic stents in patients with distal biliary obstruction? And there's never been a prospective randomized trial comparing multiple plastic stents with metal biliary stents in the setting of malignant disease. So we are currently performing a randomized trial comparing 2 10 French plastic stents to a fully covered 10 millimeter self-expanding metal stent. And our plan is to include 120 patients. Let me just carry on, sorry. So these are the inclusion and exclusion criteria, and I've highlighted the important ones. Patients need to be 18 years or older. The clinical picture must be in keeping with a malignant obstruction. It should be more than 2 centimeters away from the biliary confluence. The patient must have a bilirubin of more than 50. And the patient should be not a candidate for radical surgery. They should not have had a previous B2 or Roux-en-Y gastric reconstruction. They shouldn't have duodenal obstruction. They should not have had a previous stent, and they should not have coagulation abnormalities. The LCPs are performed at Friedrichsruhe under conscious sedation. We randomize the patients on a 1-to-1 basis to receive 2 8.5 cotton Haybruchster type stents or a fully covered metal stent, and successful stent placement is defined on radiological confirmation at the time of deployment, and successful drainage was basically defined as a 30% decrease in the bilirubin level after 5 days. So patients were followed up monthly until death or for 12 months. Stent dysfunction was investigated with a combination of liver function tests, cross-sectional imaging, and repeat ERCP if clinically indicated. Stent failure is defined as a need for re-intervention or clinical signs suggestive of stent failure or recurrent jaundice. So up until this stage, we've included 19 patients who have received plastic stents and 23 who've received metal stents, and the demographic data in the two groups was very similar. Patient survival time in the two groups did not differ significantly. Overall survival is 93 days, 80 in the SEMS group, 115 in the multiple plastic stent group. And if you look at stent patency, there's also there hasn't been a significant difference at this stage of the study, although we haven't, this was a preliminary analysis and we haven't yet included 120 patients. So it's not yet powered to show a difference, but and then the one thing that was significantly different so far is the ERCP duration is much longer in the significantly longer in the multiple plastic stent group. So SEMS and multiple plastic stents up until now have not been significantly different in survival or in patency rates. The ERCP duration seems to be significantly longer, and we plan to continue the study, and we expect to show that there's not a significant difference between multiple plastic stents or two plastic stents and metal stents in patients with malignant biliary obstruction. And if you look at these two graphs, the left one was on this trial that we did in patients with a single plastic stent. The right one is after multiple plastic stents, and this was after more or less the same number of patients. You can see that there seems to be quite a big difference. So in places where there are not metal stents available, two plastic stents would seem to be a good alternative to a metal stent in patients with malignant distal malignant biliary obstruction. So now I'm going to move on to high-risk strictures and discuss that, because this is one of the areas where we commonly use metal stents, and it's also one of the most difficult areas to achieve successful biliary drainage, and if not done properly, carry significant risks for patients. So any intervention where there's a high-risk stricture carries the risk of causing cholangitis. And I think you should be really concerned about this risk, and it should be something that you really want to avoid if you can. And the aim should be not to get contrast into any undrained segments in the liver. You must have a plan of what you're going to do before you do the ERCP. You know, you can't just rock up to an ERCP in a patient who has a high-risk stricture without having a good look at the cross-sectional imaging. That can be a CT scan, although an MRCP is often better. And the other thing one needs to consider is that there's two ways of achieving biliary drainage in high-risk strictures. It can be done endoscopically or percutaneously. And once you go up this Bismuth-Corlett classification and you start getting to the Bismuth-Corlett type 4 strictures, you really need to consider whether you should be intervening at all, because some of these patients are not actually drainable. So just a few rules when dealing with high-risk strictures, and I think it's quite important to just to have these built in if you're going to be dealing with these. Is covered stents obviously cannot be placed above the biliary confluence because of the concern about blocking side ducts. Uncovered stents become very difficult to remove from very early on because of granulation tissue and ingrowth into the stent. And they should only be placed in cases of unresectable malignancy. And that should really only be done after it's been discussed in an appropriate multidisciplinary team meeting. If you're not absolutely certain that the patient's irresectable, or you're not absolutely certain about the diagnosis, then it's not really acceptable to place an uncovered metal stent. And we have had patients where this has caused really significant problems, long-term problems, and can require open surgery if it's a benign stricture to try and remove the stent. Another point is, if you're going to try and get a tissue diagnosis, the cytology and brushings or the cholangioscopy and direct biopsies should be done before stent placement. And like I've said, you have to have a roadmap and a plan, and your MRCP or sometimes your CT scan will help you with that. And your goals should be, and the rules that absolutely can't be broken to prevent cholangitis are that you cannot cannulate or fill it. You shouldn't cannulate or fill a duct that you're not going to be able to drain. Any duct that you cannulate or fill, you should ideally drain. And you need to maintain access with multiple guide wires if necessary. Just to highlight those rules, and I don't think you can underemphasize the importance of this, and I'll show you some of the problems in the cases at the end. So I think your goals also need to be clear when you're draining hiatus strictures. Is it a bridge to surgery, or are you doing it for palliative intent? If it's a bridge to surgery, the surgery will either be a liver resection or a liver transplant, and we almost always use plastic biliary stents. There's a bit of a debate. Do you need to drain both sides of the liver, or do you just need to drain the future liver remnant, especially if the patient's going to have volume manipulation and going to have portal vein embolization? And then also one needs to consider the role of neoadjuvant therapy, and there are endoluminal therapies such as radiofrequency ablation that can be done endoscopically as well. And then if it's for palliative intent, you only need to drain 30% of the liver, and we'll usually use uncovered metal stents. And once again, there are endoluminal therapies that can be used in these patients. I've already mentioned with hiatus strictures that there's two options for drainage. There's the endoscopic and percutaneous routes, and they both have advantages and disadvantages. The one nice thing about an ERCP is, well, one of the nice things about an ERCP is that it's a natural orifice procedure. There's no external catheters as there are with a PTC. You also have the potential to access all the ducts from a single entry point. With a PTC, you'll have to have multiple puncture sites if you want to access the right and the left side of the liver. One of the drawbacks of ERCP is the risk of pancreatitis. A drawback of PTC is that when you put transversing the liver parenchyma, you can cause a vascular injury that can lead to hemophilia or injury that may preclude future liver resection. Traditionally, ERCP has been considered the technique of choice for bismuth 1 and 2 lesions and PTC for 3 and 4, but I don't think that holds true anymore. There have been a lot of studies comparing PTC versus ERCP and trying to see which is better in hiatus strictures. But there's so many confounders that I actually don't think that the question has been answered, and you'll see some papers that support one and some papers that support the other. Some of the confounders are that some of the papers have included resectable patients, some have only included palliative patients. There's a wide variety of tumors, internalization with stents or not with stents, plastic stents versus metal stents being used, and varying endpoints and varying expertise. I was trying to think of a sporting analogy, and I actually think all of these papers that look at comparing PTC versus ERCP are really missing the point. You wouldn't play rugby, or you wouldn't do a study in rugby saying should you only play with backs or only play with forwards. Some teams might have good forwards and favor using their forwards, but you're going to always have both. And I don't think you can manage hiatus strictures just with PTCs or just with ERCPs. There's some places that may favor one or the other, but you really have to have both. And in certain patients, in a lot of patients, you may need to do both. So doing studies trying to prove one is better than the other, I really don't really see the point. So I think the important points, and I think if you were to do a study seeing when you achieve this, I think you'd see that this is what determines successful drainage of biliary strictures. First of all, you need to have a pre-procedural plan, and I think achieving that plan is likely to result in a good result. There must be no filling of undrained segments. You need to avoid cholangitis by not getting contrast into segments that you can't drain. And you obviously want to do this with the fewest number of procedures possible. So I just want to show three cases. And the first two cases are cases that we have in the ward at the moment. The first is a 54-year-old male patient who presented with typical features of obstructive jaundice. No comorbidities, fit for major abdominal surgery. On examination, he has skin excoriations due to severe pruritus. No obvious ascites, no supraclavicular lymphadenopathy. His ultrasound showed no gallstones and only intrahepatic biliary duct dilatation. No features of cholangitis. His INR was slightly elevated, but he had a normal thromboelastogram. UNE was normal. HIV negative, an elevated CA 19.9, although admittedly that was in the setting of jaundice. His IgG4 is normal. Quite jaundice with a bilirubin of 423 with a cholestatic picture. So this is his CT scan. I'm just going to go through it slowly. So you can see the quite significant biliary dilatation. And if you look carefully, you don't really see a mass. The gallbladder looks normal. There's certainly no extrahepatic biliary duct dilatation. If I go back, that's sort of the point of obstruction. And just at that point, you get the impression that there's probably a mass in that vicinity, and there appears to be separation of the right and left ducts. And on the right side, it's not clear if the anterior and posterior septal ducts are communicating. So I'm going to go show you the coronal. So once again, you look at the right ducts, there certainly does appear to be separation between the right and left side of the liver. We felt that we had quite a good idea of what was going on with the biliary system, and we didn't get an MRCP, although ideally that's probably something that should be done. So I've just got a couple and just to also mention that our working diagnosis here is that the patient has a hyalocholangiocarcinoma. Patient's fit for surgery, and there's nothing to preclude a surgical resection, which would entail an extended right hepatectomy with a biliary enteric reconstruction. So you can see this ERCP being done with very careful filling and care being taken not to get contrast into all of the into the intrahepatic ducts. You can see the cystic duct and a little bit of contrast in the gallbladder. On the next view, you can see that there's pulling of some ducts on the left and on the right, but there are wires in both of those ducts, with care being taken not to lose access to the ducts that have got contrast in them. So you can see here that we've placed a metal stent on the right and a plastic stent on the left. And that ties into the way that this patient's going to have surgery. This patient will have an extended right hepatectomy. The main bile duct and the right hepatic ducts will be excised. So it doesn't matter that there's a stent that's difficult to remove in those ducts. The plastic stent going up the left side will be easy to remove and won't really affect the surgery. So that's something that's quite important, and that's why if you need to consider what your surgical options are going to be. The second case that I'm going to show is actually quite similar. 60-year-old, no comorbidities. The patient was fit for major abdominal surgery. Once again, presented with obstructive jaundice, raised tumor markers, normal IgG4. Once again, our working diagnosis is a resectable hilar cholangiocarcinoma. Once again, potentially requiring an extended right hepatectomy, probably with volume manipulation, which would involve a right portal vein embolization. So once again, careful cannulation with care being taken not to, I'm not going to show you the cross-sectional imaging, it's very similar to the previous patient. Care being taken not to get contrast into segments that you can't drain. Now, if you look here, there's a problem. We've got contrast now in the left ducts with a wire in the left duct, but there's been some spillover into the right ducts without there being a wire in that side. And it's essential that that duct on the right now be drained. Otherwise, it's going to be an undrained segment with a high chance of this patient getting cholangitis. So we managed to get a wire into that duct, and you can see us dilating the stricture with a hurricane balloon. And we tend to always dilate the hilar strictures to facilitate subsequent stent placement. And in this case, I think we were using a 4mm hurricane balloon. So then what happened is we deployed a plastic stent into the left side with good drainage, and we then attempted to place another stent up onto the left side, and we couldn't. And then we lost access, which is quite problematic. And I think this is where PTC really comes in as an adjunct to ERCP. So this patient had immediately following the ERCP went and had a PTC with drainage of the duct that had contrast in. You can see that the contrast is drained out of the left side of the liver, and we now have an internal external drain on the right. So this patient is now going to have a right-sided portal vein embolization and then potentially a liver resection. But it's absolutely an urgent situation once you have contrast in an undrained segment to get that segment drained. If that happens in a place where you don't have access to PTC, I would suggest that the patient be started on broad spectrum antibiotics immediately and be transferred to a place where adequate drainage can be achieved. The last case that I'm going to show, and it's going to be very quick, because I basically just want to show, I think this case basically ranked up as probably the worst referral of the year to our unit. And it's something that really should be avoided by anyone who does ERCPs. First of all, the diagnosis is wrong. And second of all, the technique was wrong. So if you look here, it says cholangiocarcinoma extending from the confidence to the common hepatic duct, assessed as resectable for temporary drainage. Then it says intervention was a sphincterotomy and a covered SEMS placed. Okay, so the covered SEMS was placed below the biliary confidence, and the pictures are very poor, but you can see that there's basically contrast in almost every single liver segment. So basically, if you were to set up an animal model for creating cholangitis, this would be it. And this patient was then transferred across in septic shock and spent 3 months in ICU, in multiple organ failure, and was quite lucky to survive. So this is something that absolutely has to be avoided. You cannot blow up a balloon at the bottom of a bile duct when you have a high stricture and inject contrast. And I just want to show you as the last slide, the MRCP picture of this patient. So if this was a hyalocholangiocarcinoma, it's certainly not resectable. And this is not a hyalocholangiocarcinoma. This is more in keeping with primary sclerosing cholangitis. So this patient probably shouldn't have had an ERCP in the first place. So I think I've tried to go over the indications for using plastic stents, go over a little bit of the history of stenting, and then focus on, when plastic stents really have a role. But and one of the major roles is in patients with high strictures. And when you are dealing with high strictures, there are certain rules that need to be adhered to and considered before you deal with them. Thanks very much.
Okay. Thank you very much, Mark, for a very nice talk. I don't know if there's anybody that wants to ask a question. Otherwise, there are some or any comment or have any comments. Otherwise, we have some in the chat. Maybe you can start with one of them in the chat, Mark. So Akwi Asombang asked, do you dilate malignant biliary strictures before? Well, that was the question. So I think there's two things to it. Would you just dilate malignant biliary strictures as a definitive treatment, or what about when you place stents? Do you dilate them before you place the stents?
So I think certainly for distal strictures, we don't generally dilate before we place the stents. I don't think that's usually necessary. Sometimes if you're trying to put in multiple plastic stents, it can be difficult, and it might help in that situation. With high strictures, especially if we placing stents bilaterally, we do tend to dilate them, but that's more to facilitate the stent placement. We would never dilate a stricture and not stent it. I don't think that's adequate management. So yeah, we do dilate them, but not as like the definitive treatment. The other thing is, it's not something that we often do, but if you place a metal stent and it looks very, very tight, you could put a balloon in and just stretch it a little bit to facilitate drainage after you've placed the stent as well.
Just the next question. I see there's a few more here. Let me just get it to a more viewable format here. Right, let me just get them here. The next question was from a supply distribution perspective. Where do you obtain your biliary stents? Are they easily accessible? That's also from Akwi Asombang.
So, yeah, I mean, our stents are easily accessible. With the plastic stents, I'm not sure that it really matters what stent you use. With biliary stents, everyone has their preference. We like to use we like the Boston Scientific metal stents. They're very nice and easy to deploy. They're very visible on screening, and that's, if I could choose a metal stent to use, I would use the Boston Scientific metal stents. And that one other thing, sorry, on that, it's quite useful if you are going to be dealing with biliary strictures to use a short system. It's probably more important than the type of stent that you use, is to use a short system as opposed to a long system. I think that makes a big difference. It gives the endoscopist a lot more control over the procedure.
Mark, just another question there. How soon after a PTC can you safely perform an ERCP, specifically thinking of air embolism?
You can do them. I mean, as you know, Ed, you can do them simultaneously, and that's probably the ideal, is to have a setup where you can do them simultaneously. The ideal situation, I think, would be to have a patient who's lying supine, intubated, and you can scope them and do the ERCP and have the facility to do ERCP at the same time and be accessing the biliary system from the bottom and the top at the same time if necessary. That's the ideal situation. It's not always achievable, but that's ideal. So you can do them at the same time.
Yeah, I suppose that, I mean, there's a potential risk that if you have been puncturing and you punctured, there was a venous puncture, that one way or the other there is, even if it's a short while, that there's a fistula between a bile duct and potentially between the portal vein and the bile duct, that you can inflate some CO2 into the system. I think that's probably, I cannot recall that I've seen that, but I think that would be
I suppose it's another reason to use carbon dioxide during your endoscopy, because that's probably going to be less harmful than air. Yeah.
Just one more question, Mark. So the two guide wires that you get in, or can you just explain the methodology of placing two plastic stents? You put two guide wires.
Yeah. So if you're going to go up the like in those cases that I showed, so you get your first guide wire up, let's say into the left hepatic duct. You then leave that guide wire in. You come out with your sphincter term. You go down you reload the sphincter term with a new wire. You go down next with the sphincter term next to the wire. You cannulate the bile duct, and then you try and get up the other side, or wherever you want to go. Then you'll have the two wires up. The reason why in that trial we use 8.5 French stents and not 10 French, because I do think there's probably a slight benefit in using slightly bigger stents, but if you've got a guide wire down your channel, two guide wires, you can't easily feed a 10 French stent down the channel, whereas an 8.5 French goes down the channel very easily next to another guide wire. So if you're putting in two metal stents, if you're putting in multiple metal stents, it's much easier to use 8.5 French stents than 10 French stents. And if you're putting in multiple plastic stents, you know, where you're putting in 6 or 7, then go down with your wire, have two wires, put one stent in, leave the other wire, then come out. And I think I'm not sure if you agree with me, then you'd always keep one wire in and then keep on replacing the second wire.
I think it's very important to work over two wires, and once you've placed a stent, you put another wire back, so there's two, up to the point where you know this is your last stent going in, and then you put it over the guide wire that always kept the access. I suppose one of the advantages of putting double stents is we more and more do not do PTCs on the cholangiocarcinomas, and do transpapillary drainage on these patients. And putting two stents in the hilum is quite challenging, or can be quite challenging. And if you've got a habit of doing it through the papilla, that just for distal strictures, that you already have sort of your fingers are quite good at already managing those guide wires and putting double stents.
I didn't mention it because this talk was on plastic stents, but I mean, you can also obviously put, if it's an irresectable case, you can put bilateral uncovered metal stents, and that also can be a bit tricky, because you have to then get one of the guide wires through the stent, and then you sometimes balloon dilate to make a hole, and then pass the stent through that hole so that you can get it through to get bilateral stents.
Just one other question, Mark. So the cost difference between putting two plastic stents and a metal stent. I know we pay for metal stents probably in the region of, suppose, about $500, and the plastic stent for us is probably
about $50. So it's probably about 10 times more expensive.
I think that cost analysis one will have to, I think in places where people pay per minute for theatre time, you'll have to consider that as well. But our situation, I think that will be the situation in many of our, for many of our colleagues on the continent as well, is that we've got our facility available. It's paid for in any case. Patients, especially in our public service, do not pay per minute. So whether we take longer doesn't really matter in terms of cost. And then when it comes to consumables, it's quite a significant cost, I think, that we save, if that, or could save, if it turns out that 2 plastic stents would actually do the same job well.
So one of the other things, I mean, obviously, like I mentioned, the time and that it takes longer to put in 2 plastic stents. I mean, I suppose the one benefit of that is I do think it upskills everyone, like because it is more difficult to put in 2 plastic stents than a metal stent. But there's definitely an audible groan during the trial if we pull out the envelope and it's a plastic stent, because you know you're going to be there a bit longer than you would be if you're putting in a metal stent. So, you know, it is cheaper, but it's more difficult. But it's probably equally as good, although we don't know that for sure yet.
Yeah. The other thing I just want to mention, you mentioned for benign strictures that you can put a fully covered metal stent. And if you don't leave it in too long, it will sort of serve the same function as multiple plastic stents. But we've had problems with patients where even after maybe 3 to 6 months, that the plastic coating on the stents give and they become uncovered and then they stuck. So I think that's something that one has to consider as well. And the other thing is your maximum diameter that you achieve with a single metal stent is millimeters. That's the max stents that we have. Whereas there's actually no max diameter on what you can achieve with plastic stents. I mean, 10.
That's one of the pros, yeah. So you can go up, but it's interesting. I didn't realize it's 7 10 French stents to 10 millimeters according to, so that's quite a lot of stents to put in actually. Yeah.
If you put 7 French, yeah.
Yeah, 10 French. They said 7.
Yeah, 10 French.
Yeah.
All right. I don't know if there are any other questions or comments. We're a little bit of ahead of time. So if there's anything, please speak up or post. And if not, I think we can conclude. Chris, do you want to say something?
Oh, no. Just showing my presence. So, you know, I'm not sleeping.
Okay, thanks very much, Mark, for a very nice talk. And again, thanks to the University of New Mexico and ECHO India for their support. The recordings of all these sessions will be or are available on the Gastro Foundation website. Also to thank the Gastro Foundation that arranged these for us. Thanks to our sponsors. And then just next week's session will be on pediatrics or pediatric gastroenterology. And I think there we've got the announcement. All right. Thank you very much, everybody.
Thanks a lot.